a bit unusual because hot flushes are not the most common symptom of perimenopause or menopause, but they're actually something that are talked about a lot and cause a lot of confusion often for many people. So I thought I would start by talking a bit about the history of menopause, which some of you might be wondering why, but actually a lot of the confusion, the concern, the unfounded fears about hormones are based on history and misunderstanding. So, when hormones were first discovered in the 1930s, they realized that there was something in the ovaries that was causing a myriad of symptoms when the ovaries weren't there, because they realized when women had their ovaries removed, an oophorectomy, they developed symptoms. And they knew quite early on, actually, that mental health symptoms were more problematic than the vasomotor symptoms. And when we say vasomotor symptoms, we mean flushes and sweats. When they discovered hormones, especially estrogen, they realized that giving those hormones back reduced symptoms and people felt better. And there's lots of descriptions from the 1940s, actually, where women's mental health improved, women's physical health improved when they were given hormones. And as early as 1941, it was discovered that bone density, so bone strength and risk of osteoporosis, reduced in women who were given hormones. Now, as you know, for many, many decades, women weren't involved in studies because they didn't have to be. And in fact, it was as late as 1995 where regulations changed that women had to be included in studies. It's awful, isn't it? Anyhow, they couldn't do studies on menopausal men, of course, because men don't have ovaries. So there were a smattering of studies on women. Now, women, as many of you know, are often not believed. They're not listened to, they're not understood. And many of our symptoms are put down to hysteria, they're put down to trauma or stress or being unable to cope with various life circumstances. So when people are doing studies, they want things that they can easily measure. And most studies in the past, but certainly in the 40s, 50s, 60s, and 70s, were done by men because the men were the scientists, of course. The women weren't scientists, they didn't do academic jobs. So men wanted something that they could measure quite easily. They didn't want any subjective measurements, because if I told you that I felt a bit tired yesterday and I'm telling you I feel a bit less tired today, how do I measure that in a study? How do I measure mood? How do I measure fatigue? How do I measure memory loss? It's easier now because we do have some more validated questionnaires, but back then it was very difficult. So they wanted symptoms they could measure. Now, if someone is having a hot flush, you can often see it. You can often see the drip sweating off their forehead. You can see them often flush. They can be redder in their face. They can be, fanning themselves. So that's something that they could measure with a clipboard, if you like. So this is why hot flushes have always been used in studies, because it was something that you could see and measure. You could specifically say to a woman, how many hot flushes have you had in the last hour, in the last day? How many night sweats have you had? How many times did you wake up dripped in sweat? And that's something that's measurable. If I said to a woman, how many times did you wake up in the night worrying about what you were doing the next day, or catastrophizing about something you wouldn't normally worry about, then it would be very easy to say, well, that's just because you weren't sleeping well or you had other things on your mind, not that it's related to your hormonal changes. So historically, vasomotor symptoms, flushes and sweats, have always been given a priority for clinical research. And that's why so often menopause studies have been looking at treatment improvement, and they've used flushes and sweats. Now, the other symptom that's very common, which I'm not going to dwell on today, but I think it is interesting, is vaginal dryness. And one of the ways that they used to try and determine whether a woman was menopausal or not was to examine her vulva and vagina and look for changes in the cells. Now, a lot of research was done on our womb as well, but also our vulva and vagina. So if people had changes, physical changes to the skin, to the tissues, even changes to the cells, then they could diagnose menopause. And they could also diagnose improvement to treatment. So if those cells and the physical changes improved, they would say that the treatment was helping. They didn't do blood tests for hormone levels then because they didn't have them available to them. So a lot of research again has looked at vaginal dryness because that was a measurable, a quantifiable test that they could do examining women. So even now, if you look at the NICE menopause guidance in the UK, they will say symptoms of menopause include vasomotor symptoms, flushes and sweats, and vaginal dryness. And that is because most treatments for perimenopause and menopause, the studies have really just involved those symptoms because they are measurable. Now we know as menopausal woman, and also as I know as a doctor who's a menopause specialist, but I also know from talking to and surveying many, many thousands of women that the most common symptom are symptoms affecting our brains, not our flushes and sweats. And a survey we did of around 4,000 women found that 68% of women had flushes and sweats, but the vast majority, over 90%, had symptoms such as brain fog, low mood, anxiety, fatigue, poor sleep. All of those things that I've already said are quite hard to measure in clinical studies. Now, why do hot flushes and sweats occur? Well, as I've explained many times before, we have cells all around our body, in our tissues, in our organs, that respond to three hormones: estradiol, progesterone, testosterone, as well as many other hormones in our body. Now, when levels of these hormones fluctuate or change, the cells in our tissues and organs don't work as well. In our brain, we have lots of different areas that have different jobs. So we have areas of our brain that determine our mood, our personality, our memory, for example. We have areas of our brain that determine our pulse rate, so that our heart rate, our breathing rate, our metabolism, even how we metabolize food is regulated by our brain. And there's an area in our brain, and an area called the hypothalamus, and this contains our thermoregulatory center, if you like. It's our thermostat of our brain, and it helps regulate our temperature. Now, if we go into a hot room, immediately our brain and our body determines that we're in a hot room. So as many of you know, we feel warm. We have vasodilatation, which means our blood vessels expand, they come to the surface, we become red, we become warm, and that's to try and cool down our body. And there are signals going to our brain telling us we're warm, so maybe take off our jumper, take off our coat, our scarves, or whatever. And conversely, if we're cold, then our body and our brain lets us know that we're cold, and then our blood vessels constrict. They try and keep all that warmth in the blood as close to our organs as possible to keep us as healthy as possible. And this hypothalamus is constantly checking on the temperature in our brain. Now, we know that lots and lots of hormones determine how our hypothalamus works, but there's been a lot of research looking at the way estradiol especially determines and affects how the hypothalamus, this thermoregulatory zone in the hypothalamus, works. And when there are changes in levels of hormones, then there are hormones produced in our hypothalamus. There's like a feedback, if you like. So there's a constant feedback of our estradiol that's made in our ovaries, our adrenal glands, our other tissues that go in our bloodstream, and then hormones from our hypothalamus that are produced, which have a feedback. So these are releasing hormones, if you like, and they're called gonadotropin releasing hormones. So they help release the estradiol, progesterone, testosterone. So if levels of gonadotropin releasing hormones reduce, then we've got an increase in estradiol. It also regulates our luteinizing hormone and follicular stimulating hormone. And these hormones are very important for our fertility. The ratio of these hormones determines the ratio of our natural hormones, estradiol, progesterone, testosterone, which, as you know, have a peak when we ovulate. So our body is incredible. It's constantly changing and looking at our microenvironment, looking about what's going on in our body, what's affecting these hormonal changes. And so studies have shown that when there's a big change and fluctuation in especially estradiol levels, this affects levels of gonadotropin releasing hormone. It affects the hypothalamus and the pituitary, two important areas in the brain. And this can trigger these hot flushes. And hot flushes can mean different things to different people. Some people literally just feel hot. Others feel absolutely drenched in sweat. They feel incredibly hot. And some people say it goes from their head down to the rest of their bodies. Some people say it starts in their toes and gets this wave going up to the top of their body. Some people actually describe it as cold shivers. So it's a bit of a misnomer calling it hot flushes, because some people don't flush and some people don't feel hot. They feel very cold and shivery, and that can occur due to hormonal changes as well. Now, traditionally, some studies say, well, hot flushes and night sweats are the same. A night sweat is just a hot flush in the night time. I don't quite agree with that, because often people who have night sweats feel incredibly sweaty. And I had night sweats, but I never had hot flushes. And I used to wake up literally drenched in sweat. I could just feel this film of cold sweat all over my body. Not on my face, actually, but usually on my chest, my arms, and my legs, to the extent that sometimes I woke up and thought that I'd wet myself. It was absolutely horrible. But I never once felt hot. I never had to throw the duvet off. In fact, sometimes I felt a bit cold because of this puddle of sweat that was on me. So I don't think it is the same as hot flushes. I think some people do get hot flushes at night time, but some people just get these drenching sweats as well. And whether they're triggered by changes in the hypothalamus and pituitary or not, it doesn't really matter. I think a lot of this discussion as to how the hot flushes and the night sweats occur, all the research, in some ways is a waste of time, because we want to see what's going on, what's causing it, and what can we do about treating the cause. We know the cause is due to fluctuating and changing hormone levels. We know it's related to reduction in estradiol, but also low progesterone and low testosterone can cause these vasomotor symptoms, these flushes and sweats. And often people find they're worse in the perimenopause when these hormone levels are really fluctuating and changing. Testosterone levels decline with age, so they often start declining in their late 20s, early 30s, and they carry on declining slowly as we get older. If someone has their ovaries removed, about half of our testosterone is made in our ovaries when we're younger, so their testosterone will decline even quicker. And testosterone deficiency can be associated with flushes and sweats as well. Lots of people think it's only estrogen, and it's not actually. It can be related to all three hormones or just one hormone differently in different women. So some people might have these symptoms more because of estradiol deficiency, and some it might be more because of progesterone or testosterone deficiency. The way we respond to changing hormones is all different because we're all individual. So we need to be thinking about the underlying cause. We need to be thinking about, let's treat these low and fluctuating hormone levels. Let's not just treat the flushes and sweats, because we're not treating the underlying cause. And this has caused a myriad of confusion, I think, amongst healthcare professionals and also from women as well. Also, if you look back in history, when they discovered these hormones, they quickly labeled some deficiency of hormones with diseases. So if you think, when they discovered insulin, they determined, or they defined the word diabetes. And we know type 1 and type 2 diabetes are diseases. They're associated with insulin deficiency with type 1 diabetes. And we treat type 1 diabetes because without insulin, people become very ill. And we regulate the insulin levels very carefully, because when they're in the normal range, people, men and women with type 1 diabetes, have a lower risk of heart disease. They have a lower risk of kidney disease and dementia and chronic diseases, which is really important. When they discovered thyroxine, they labeled, it was Graves, so Graves' disease. Graves was a researcher, an endocrinologist, but they also, hypothyroidism and hyperthyroidism are associated with diseases, and we treat those as well. When they discovered estradiol, it was associated with flushes and sweats because, like I say, the experiments were ones that they could measure the flushes and sweats. So quickly it was defined as a symptom, estrogen deficiency, not as a disease. Now, I'm hoping you know, in 2025, we often treat women with hormones, obviously to improve the way they feel, but more importantly, to reduce their risk of further disease, like heart disease, like osteoporosis, in the way that we treat diabetes to reduce risk of diseases. But it's become so confused now that people only think it's related to symptoms, and that's often related to history in the past and the way that studies have reported the evidence. There's also been a lot of studies where people have been told off almost for talking about the effects, the beneficial effects of hormones. And I was reading some work today that was written in the 1940s, the 1960s, and the 1970s from people who described how estradiol is better than placebo for managing hot flushes. And there was quite a few toing and froing articles in the British Medical Journal from different academics where saying, actually, it's no different to placebo. And other people saying, of course it is. Why are you being so ignorant? And I was really surprised actually to read these articles because it just made me realize that in the history of medicine, women have been put down and they've been all told it's in our heads like placebo will help. We know placebo can help with many, many conditions, but we don't compare an evidence-based treatment to placebo once we've got the studies showing the evidence-based treatment works. We move away from placebos, whereas often it's all about placebos and how that can help. Now, a placebo may or may not help my night sweats, but it's not going to help reduce inflammation in my body. A placebo is not going to reduce my incidence of heart disease and osteoporosis. And like I've said before, my choice as a menopausal woman is to take hormones to reduce my risk of diseases, especially osteoporosis, a disease I'm very worried about getting because 1 in 2 women will get osteoporosis when they're menopausal and don't take hormones. Placebo won't strengthen my bones. So we have to get away from this placebo argument. So I thought that would be useful for you just to understand the history and also a bit about the science of why flushes and sweats occur in women with hormonal changes. Now, some people have asked how long do they last for? Now, it really, really varies actually. Everybody's different. Of course, we're all different, but some studies say that they can last 7 to 10 to 12 years. That's ridiculous length of time. Why would we let people suffer when we've got an evidence-based treatment? So it's not about how long are they going to last for. If you're getting any symptoms, you should be thinking about treatment. I've seen some women who have had vasomotor symptoms, flushes and sweats for decades, literally 2, 3, 4 decades. They've had a oophorectomy many, many years ago. Then their vasomotor symptoms started. They were told they could never have hormones. And then I see them when they're in their 70s or even 80s and they're still experiencing symptoms. So there's no magic age where they're going to stop. There's no magic number of years that people are going to get them. It can really vary between different people. Some people think that it's the flushes and sweats that increase the risk of heart disease and osteoporosis and other inflammatory diseases. And some papers you might see and read say, are hot flushes the cause of depression, the cause of Parkinson's disease, the cause of osteoporosis? Of course they're not. It's the underlying cause of all of those things, which is inflammation caused by the low hormone levels. So we need to get away from, if we treat the hot flushes, everything else will improve, because we're not treating the underlying cause. And this is really important when we think about how do we manage flushes and sweats. Well, in medicine, we usually treat the underlying cause. The underlying cause is low hormones. We work out which hormone it is. Is it estradiol, progesterone, testosterone, or is it indeed all 3 of them? We work out the right dose for that individual and we give it back, and we monitor those people closely to see if the dose needs changing at all or the formulation needs changing to really optimize it for them. Now, some people go for other treatments because they're worried for often the wrong reasons about the safety of hormones. We tend to give the natural body identical hormones, which are really important. Now, actually, there are over-the-counter treatments, or I say treatments in inverted commas, because it can really vary. A lot of these treatments might help the flushes and sweats. There's treatments like sage, for example, or some herbal supplements might or might not help, but they're not going to help improve future health. And this is why we have to question why we're taking various medications or supplements when we don't know what they're doing to our bodies and we don't know whether they're helping our future health. And then there is a new treatment called fezolinetant. There's another one called I can't even pronounce it, ezolinetant. These are both neurokinin receptor antagonists that have been developed over the last few years by 2 of the drug companies, Astellas and Bayer. Now, they've been researched for many years because they were initially designed as neuroleptics, medication for people with schizophrenia. They weren't found to help, but they did notice that in some of those studies, women that were feeling hot felt less hot. So they thought, well, let's try them for menopausal flushes and sweats. The studies that have been done so far are quite short-lived. They're not very long-term studies. They've only really been looking at flushes and sweats. Some of them have looked at sleep as well, and they have shown an improvement compared to placebo. But we have to think about how they work. They're neurokinin receptor antagonists. Neurokinin receptors are in the thermoregulatory part of our brain in the hypothalamus, but we also have these receptors all over our brain and our body and our ovaries, even in our bones as well. So blocking these receptors may or may not be beneficial. They also block something called kisspeptin, which is a protein in the body which blocks and helps protect from growth of cancers or spread of cancers. So this is a concern as well. If we block something that's a naturally occurring protein that's good in our bodies, we have to be really clear as clinicians that we're not doing harm to patients. There is one study in the Lancet showing that women who took this drug, fezolinetant, had a small increased risk of cancers, of epithelial cancers. It was only one study, but other studies that have been set up aren't looking at cancers. We don't know whether it increases risk of recurrence or even if it increases risk of recurrence in women, for example, who've had breast cancer. And there is quite a lot of marketing of these drugs for women who've had breast cancer for their flushes and sweats. Well, there are three things really that concern me. Firstly, any new drug concerns me because I don't know long-term safety data. Secondly, they've never been studied properly on women with breast cancer. And thirdly, they're only helping flushes and sweats at best, or they might help a bit of sleep, but they're not replacing missing hormones, they're not improving future health. We don't want to be giving women a treatment and saying, there you go, your flushes and sweats have improved, therefore your menopause is treated. We need to be looking, if women don't take hormones, of ways of improving their cardiovascular health, their bone health and their brain health, not just giving them a chemical that we don't know the consequences of. But I have done a podcast about this, and there's an article on my website about fezolinetant and the neurokinin receptor drugs. We need more data, but I don't think they should be used because people are scared of hormones, because we need to be looking at the evidence for hormones, and we need to be looking at the evidence and risks, so benefits and risks for these new treatments that have quickly come on the market. And many menopause societies and menopause specialists are funded by Astellas and Bayer, which make these two drugs. So we have to be really careful about any potential conflicts of people that are talking about these drugs. And as many of you know, I do no paid work with any pharmaceutical company. So my knowledge comes from evidence, not from any bias at all. So we're running out of time. I think there might be some questions, so I'm going to put my glasses on and just go to the chat. So one of the advantages of doing the Instagram lives now on Facebook is on YouTube is that so we can I can look at some of the chats, and it's just easier to monitor than it is on an Instagram live. Someone's saying, what shall I take, progesterone or estrogen for night sweats beginning second week of cycle? Now, if people is having progesterone for 2 out of 4 weeks and you find the 2 weeks you're not taking progesterone, that you're getting sweats, then it's probably related to low progesterone. People can take progesterone every evening. It's worth talking to your doctor about it. The only reason we start in a cyclical preparation is otherwise people get a lot of breakthrough bleeding. I'm perimenopausal, regular but skimpy periods, night sweats, occasional headaches. She's on Everil Sequi. So Everil Sequi, I've explained before, is a combination patch. The Everil bit is the natural estradiol. The Sequi bit is a synthetic progestogen. I tend to prescribe the natural estradiol and the natural progesterone, which is the micronized progesterone. Progesterone can be given orally or vaginally or rectally as a pessary, and that way you can get the dose and type right. Often we do estradiol levels, and if the level's low, we consider changing the dose or the formulation of estradiol, and the natural progesterone is going to help flushes and sweats and symptoms better than synthetic hormones. Should I still get hot flushes being on HRT? No, if the flushes and sweats are caused by a hormonal deficiency or insufficiency, then having the right dose and type of hormones will improve your flushes and sweats. Now, there are other reasons why people get flushes and sweats, some other medical reasons. So, if someone hasn't improved, or if they've got symptoms that aren't suggestive of perimenopausal or menopausal symptoms, as doctors, we're always asking lots of questions. We're trying to build up a history so we make the right diagnosis in women. If I see a woman who's got normal estradiol levels, she's got a normal good dose of progesterone, she's got normal testosterone levels, and is still having symptoms, then I will always be thinking, is there another reason? Is there something else why this person might be having flushes and sweats as well? Oh, that's very nice. Someone said, thank you for your giving up time for your day. I just feel this is an important way of getting information out to women. So many of you have questions, and I know so many of you find it really difficult to access a healthcare provider or somebody. And when you want to ask questions, it can be really difficult. I'm just going to, there's another question popped up here. I'm on bioidentical HRT, stopped my red clover thinking my HRT would sort out my hot sweats, then my night sweats returned. Should I go back on the red clover? Well, red clover might or might not help flushes or sweats, but it's not treating the underlying cause. It probably contains phytoestrogens, which are chemicals similar to estrogen that might partially stimulate the estradiol receptor, but it's not the same as having the real estradiol. It's possibly a bit like having a synthetic estrogen. In my mind, you always want to replace like with like. Bioidentical hormones aren't licensed or regulated, and you have to be very careful the preparation that you're taking. But it's not whether it's always bioidentical or not, it's about how it gets through the skin. I recently changed my formulation of testosterone because I wanted to just try the gel rather than the cream. And I've spent the last 3 days with an awful migraine, joint pain, and just feeling exhausted. It might have been a coincidence, but I don't think so. I just don't think I absorbed the gel very well. Other people find doing it the other way around can be better. So we just have to find what's right for us as individuals. And really important, that's why working closely with a menopause or hormone specialist with you as an individual is worth it, because making sure it's the right dose and type. So it's not just the dose, it's about how it gets through the skin is crucially important. And we can change so often, like I've said earlier, if we're in a warm environment, our skin becomes warmer, our blood flow becomes closer to the surface of the skin. So anything we put on our skin will get absorbed easier than when we're cold and our blood vessels are deeper into our bodies. So things are constantly changing. And so we have to be very agile when we're giving hormones through the skin. So I wouldn't be giving people supplements if I hadn't optimized their hormones properly. So it's always worth just making sure that you're on the right dose and type of hormones. So I hope that's been useful, and I will look forward to speaking to you next week. I'm going to be talking about PMDD and PMS, so premenstrual dysphoric disorder and premenstrual syndrome, and I'm going to have another hormone specialist with me, Dr. Hannah Ward. So we're going to do a bit of a double act. It will be because it's the end of PMDD Awareness Month, and it's something that is very underdiagnosed and very undertreated and can be transformational for women if they receive the right type of hormones, often progesterone. So we're going to be spending some time talking about that next week. So thanks very much, and speak to you soon.